So my background is rooted in psychiatry and severe mental illness, and that is the population that I worked with back in the UK before moving here February 2023 to Spokane. Since moving, I work more now with people with brain injury, people with neurodegenerative diseases, and for the sake of this project, people with opioid use disorder. Since moving here, I now work with people with opioid use disorder. So the primary project that we work on with the opioid use disorder population is the hyperbaric oxygen therapy project. And that is run primarily by Dr. Matt Layton and Dr. Marion Wilson. And I act as study coordinator for that. So in that project, we're looking to help people who are on methadone for opioid use disorder reduce their methadone dose without experiencing such difficult withdrawal symptoms. And we're hoping that the hyperbaric oxygen therapy, or HBOT, will help them do that. My part of the project for HBOT, primarily I run the day-to-day coordination, I look after the participants, I get them screened, consented, get them to meet the doctor, and then I'm there with them every day that they're there for an oxygen session. A side project to that, which I am in charge of, is the qualitative project, where I'm interviewing people about their experiences, not only while they were in active addiction, but as they found their way through recovery as well. So I asked them things like, what was their turning point? What happened to them whilst they were in active addiction that made them think, I need to take a step back here and look for treatment options? That's a really important part of the research, and people tell me incredible stories when we get to that point. They also talk to me a lot about the methadone clinic, and they speak to the barriers, the facilitators of what it is to be a patient there trying to access care. We talk a lot about social stigma, and we also talk a lot about childcare, family care more broadly, employment, finances, maintaining a home. And yeah, overall I just get to have a really great conversation with these people, work out what it's like to be a patient on methadone for opioid use disorder. And we also look a lot at alternative and complementary treatments as well, because the participants we have are really, really looking to get better. They want to get off their methadone. They want to live a different life than what they are now. So they're involved with us because they want that extra treatment. So a lot of our conversations also talk about alternatives, additional treatment, therapy, counselling. So we have the main point of their story is their opioid use disorder. Going broader than that, we then look at their methadone, and then even more broadly than that, we look at the alternatives, including the hyperbaric oxygen therapy. So around 70% of the patients I speak with have had a prescription painkiller gone wrong. What I mean by that is they've had something prescribed to them and they haven't had the advice, the guidelines, the support around that medication. So it's very easy to then abuse that. It could also be that someone has been put on a medication for one period of time, they've been left on it for a long time and then cut off cold turkey or switched to a different medication that doesn't work for them. Oftentimes this has come from a surgery, an injury. I've had mothers talk to me about painkillers given during childbirth and C-sections. So they've been given these painkillers and opioids for very legitimate reasons. They just haven't had that wider support and education around what it means to take an opioid and what addiction can look like. Unfortunately, as I said, about 70% of people have this. They then get through the prescription for as long as they're on it. After that time, they have a withdrawal from that opioid, the prescription opioid, when they can't access anymore because either they've been cut off, they've had their insurance dropped or changed in a way that means they can't access it anymore, or for whatever reason they can't get their prescription. That's when a lot of people are then turning to the street drugs. That can be heroin, fentanyl. People also go to other drugs. It doesn't have to be opioids. A lot of people go to something different, but that is when people are turning to street drugs. So I think there's a lot of stigma and a lot of misinformation out there that people who are using the methadone clinic have all come from the street. They've all come just from street drugs. They've gone out recreationally to have fun with these drugs. And that really just isn't the case. A lot of people really have a prescription that just hasn't worked for them or has worked in a different way than they were expecting. And that's how they've ended up on these street drugs. Like I said, that's about 70%. I then do see around 30% who have had more of that typical or expected story where they have at some time in their life turned to substances either recreationally or through a mental health crisis, perhaps, and they have just gone straight to street drugs like heroin and fentanyl, and they've gone on from there, and now they're at the clinic. But really, the overwhelming thing I'm seeing is that people have started on a doctor-prescribed painkiller or other opioid medication, and it's just stumbled along from there, and it's hit this point where they've needed to get on the methadone clinic and the methadone program. So a lot of the patients I see talk to me about social stigma and barriers to accessing care, and the way they frame it to me is access to the methadone clinic, but the wider story is that really access to any care for this population is incredibly difficult and met with a lot of barriers and a lot of stigma. But in terms of barriers to the methadone clinic, the stories that I hear are people don't have the knowledge in the first place to, one, know the methadone clinics exist, and then two, they don't have the structure to get in the door to the methadone clinic. Even when people have those things in place, they still have a bunch of barriers in their way. So for example, if you live 20 miles from your nearest methadone clinic and you don't have a car, you have to work out how to get public transport. Public transport costs money. Some of these people don't have money, so they can't get on the bus. They're then reliant on a family member, a friend, a neighbour driving them to the clinic, and that's just to get onboarded at the clinic. That's not to turn up every day to take a dose. That's just to get a foot in the door, get the paperwork going, to be set up to get those prescriptions going forwards. So even at day one, they're faced with a multitude of reasons why they are restricted access or limited access or just general barriers. Even when people can get that foot in the door, like I said, they're then reliant on public transport or other means of transport to get them there every day. Even if someone does have a car and they can drive themselves to clinic every day, there's limited parking at the clinics I have worked at. There's limited parking available. So people have to work out where to park, or they have to pay to park, or they risk parking somewhere where if they're not out in 20 minutes, they're going to get a parking ticket. So even if they can get themselves there, that's another barrier before, again, they've even stepped in the door to take their dose. There's also a lot of social stigma surrounding clinic use and methadone use more widely. And that can be from other people in the population. It can be from other members of the general public. And also, sadly, I've heard some very sad stories from service users facing social stigma from people who work in healthcare. So again, even if people have all of the practical and physical means to get themselves to the clinic, there are these social, emotional stigmas and barriers to wanting to get in and take that medication. Even if it's something they truly want to do, there are a lot of difficulties to actually getting that done. Another thing that we're seeing, and this is actually a paper that I'm trying to write currently, is in terms of motherhood and child giving while either in active addiction or trying to receive treatment with the methadone clinic. We see it more in mothers, but I will just say, like parenthood generally, people are trying to look after their children at the same time as going through this recovery. And I see children at the clinic. People are very, very welcome to bring their children to clinic. However, that can be quite difficult for some of the parents, particularly the mothers that I speak to. They don't want to be bringing their child with them to dose because A, they don't want their child to see them dosing. B, they don't want their child around other people who are particularly vulnerable or potentially risky. And C, the wider environment around the clinic can be known to be a bit difficult. So they just generally don't want their children there. So that's another thing they have to face. Do they turn up to clinic to dose with their child or without their child? If their child's not with them, who's looking after their child? A lot of the time they don't have family support, they don't have friends, they don't have money to pay for childcare. So again, parenthood, and I do see it more in mothers, is another barrier to getting a foot in the door at the clinic. Some people who I meet with at the clinic, they have jobs that they need to attend and they don't have the flexibility always in that job to tell their employer, I can't turn up until X time in the day because I need to go to my methadone treatment program. So sometimes people have to weigh up keeping their employer happy, which is very important to everyone, but very, very important to this population, and turning up for their methadone dose. And another one of the barriers potentially as well is housing. A lot of the people that we work with are unhoused or they're in halfway homes, and a lot of the time they then don't have a means of transport, means of communication, anything. So sometimes they can't turn up to appointments, they can't call ahead and try and reschedule an appointment. There's just no structure for them to get in touch with anyone or really make any plans for themselves as well. And we see that a lot in the unhoused community with the methadone clinic. So a patient that I met at the clinic recently was talking to me about her experiences during her pregnancy and childbirth as someone on methadone for opioid use disorder. And she spoke to me about her methadone dose being increased during her pregnancy, and that's typical. We see that quite often. And she was on a split dose, meaning that she dosed twice a day, once in the morning, once in the afternoon, but both were of an increased dose during her pregnancy. She went through her pregnancy, there were a few complications, nothing major, went through the pregnancy, but she did have an emergency birth. Now, I'm not sure if that was C-section or otherwise. But she was brought in for something else, ended up having the baby in hospital way before she planned to. Baby was fine, she was absolutely fine, the mother went home, but her methadone dose after the childbirth was not changed. So it did not come down. So she was still on the increased pregnancy methadone dose. The story she was then telling me was she was at home with her baby. From context, I feel like she had been home 1, 2, maybe 3 weeks, not a long time at all. The baby was still very much a newborn. And she had taken, I believe, her morning dose of methadone, was going about her day. She then took her afternoon dose of methadone, started to feel out of place, out of sorts, felt very, I believe her words were that she felt like a zombie. And she said in that moment she had fed her child, she had burped her child, she had her child in her arms after dosing. And as she felt this overwhelming feeling of being a zombie come over her, her body relaxed so much that sadly she dropped her baby out of her arms, luckily sort of down her body. And she explained to me she was in this reclined position, she was low to the ground, so luckily the baby only went from arms to lap to legs. But in her words, she told me it was very traumatizing and she felt that her baby could have died. And this was all because she was on too high of a methadone dose after her childbirth, and no one had caught up with her after the childbirth to re-regulate that dose and bring it back down to a non-pregnant dose. But in her words, she said it was incredibly traumatizing. She really felt like her baby could have died in that moment. She said she did her absolute best to come round from this state that she was in as it happened. She called the nurses, she called the doctors. People came round and checked on the baby. The baby was absolutely fine. Not even a mark were her words. So the baby was completely fine. She was physically fine, the mother, if not emotionally, very shaken up. But that's a story she still remembers now. And I can't remember exactly how old her daughter is now, but she's now a full-grown child, and it's still a story that this mother remembers, is feeling these zombie effects of her increased methadone dose to such a state that she dropped her baby. And I couldn't believe when she told me that. I mean, I could, but it was just devastating to hear her say that. And in that interview setting, I work really closely with people. I meet them several times before we have that interview. We do have a good rapport. But for someone to open up and tell me that story about dropping their baby to a point where they thought their baby was going to die, I've never had an interview like it, and I hope to never have another one. It was terrible. Yeah, so I'm very lucky in the position that I'm in as a qualitative researcher. I speak to patients weekly. I was going to say daily, but weekly. And I know from their stories, from stories I hear at the clinic, from stories I hear from staff members, healthcare professionals, I know, and I know that my wider team know, that the opioid crisis in Spokane and in Washington is devastating. It's bad now, it's getting worse, we're still on that uphill spike. However, there isn't the quantitative data set to prove that and to use in things like grant applications to get research conducted for this area. So me and my group, the wider group, we have tried before to get data together that says this is how many people in Spokane are opioid users, are facing opioid overdoses or deaths from opioid use. And that could be fentanyl, heroin, any of it. We just don't have those numbers in one confirmed place, one confirmed database to pull from. So when we're trying to make research plans to better the opioid crisis here in Spokane and in Washington, we just don't have the data to pull to make that argument, even though we all know it's very true, it's very real, it's very live and happening now. Anyone you speak to at the clinic, be that patient, healthcare provider, everyone knows this is a bad problem that's only getting worse. We just don't seem to have one cohesive data set that allows us to say that statistically, which is a shame. So in terms of community among the people that I work with at the clinic, they speak to me about that in two main ways. Some people are incredibly lucky and they have a family, they have a group of friends, they have outside groups from church, hobbies, from work or neighbours. The people that have those groups speak incredibly highly of them, and you can tell how important that is for them in their recovery. So in terms of, like I was speaking to you earlier, with barriers, some people that don't have that access to transport, if they have a family member or a friend who can take them, not only is that a great physical, practical thing to get them to clinic, but having that person who supports them in their recovery is also incredibly valuable to them, and they recognise that. They know how important those groups are. Sadly, the majority of people I speak with don't have that community. They don't have family. Either their family don't live locally, or their family are local but are not willing or happy to speak with them because of their addiction and because of their life surrounding addiction. A lot of people at the clinic don't have a wider social network either. They don't particularly have anyone they would count as a friend. They don't have anyone that they would particularly rely on or trust or put any faith or stock into. Unfortunately as well, these people often aren't working, so they don't have colleagues they can turn to. They don't have, a HR system where they can go to access mental health care or anything like that. They just don't have these systems around them. And I think sadly, most of the people that I speak to, especially those that aren't doing very well, they don't have community, they don't have groups, they don't have a network, and they report to me that they feel alone. And sadly, that does then eat into the rest of the issues they're having. And to speak to trauma, a lot of the patients I work with do have some deep, often interpersonal, domestic, sexual abuse trauma in their history or ongoing. Sadly, people still live with partners who are abusive. People are still living in halfway homes that aren't particularly safe. So not only are these people marginalised by the wider society, they then don't have their own community, they don't have their own support networks, and then wherever they are, they're faced with more and more traumas on top of the trauma that they very likely already have. So something that's really valuable to the patients at the clinic is when there are group sessions, so group therapy sessions. And this is valuable for everyone. It could be that you don't have a wider network or that you do have a wider network. Kind of regardless of that, people that attend the group sessions really find value in it, because to them at least, there's no one else in the world who understands what they're going through than the person sat opposite them, also going to the methadone clinic, also dosing, also with opioid use disorder. So the people that can attend those group sessions when they happen really value them. And I don't want to put words into anyone's mouth. I don't think they consider these people, necessarily friends, but they do have this wider network of at least, I don't know what to call them if not friends, but, partners in this. And a lot of people do really enjoy the group therapy sessions because also it allows them to speak about things very openly. And a lot of times people who I meet with anyway, if they are isolated, they don't have anyone else in their world who understand what they're going through. And sometimes people are embarrassed by what they're going through and they don't want to speak about that. Even if they have someone in their life that they can speak to that, they don't want to. They find it very embarrassing. There's a lot of stigma. There are some very personal issues to opioid use disorder and recovery that aren't very well accepted by wider groups. But if you can sit opposite someone who's going through exactly what you are, knows what methadone is, knows what opioid use disorder is, you can speak more freely and with less embarrassment. So I think the community and the network that comes from the group therapy sessions at clinic are really, really important. So although a lot of the patients I speak with have some barriers and some things they don't love about clinic, one theme that comes through from nearly everyone I speak to is that they have had a good relationship with their counsellor at clinic, with their therapist at clinic, or just the staff that see them day to day, the dosing nurses, the staff that welcome them in. And those positive interactions really mean a lot to this group. And I can quote nearly word for word a participant saying to me that they wouldn't be here without the clinic, or that they wouldn't be here without methadone. So although it's not an easy lifestyle, although it comes with its challenges, although there is a lot of stigma, a lot of barriers, people who are working through the program really do see the value of methadone, and they see the value of being a part of a clinic, speaking with therapists, speaking with counsellors, and they really, from my interpretation of what they tell me, a lot of people owe their life to methadone and they owe their life to the clinic. And I believe them when they say they really wouldn't be here without it, from the stories they've told me about trauma, about mental health, about comorbid substance abuse and use. I truly believe people when they tell me they wouldn't be here without methadone, they wouldn't be here without the clinic. So although a lot of the patients do talk to me about being on methadone as a positive thing, they do see it as a positive step in their recovery, a key theme that comes up when I interview patients, or indeed just when I speak to them generally at clinic, is that they feel methadone gets in their bones. And that is something, again, the majority of people have told me about, have discussed with me, have shared with me, and people use that phrase differently. So some people truly believe that chemically the methadone is getting into their bones, making them weaker, making them frail, fragile. Other people, when they tell me that methadone is in their bones, they mean more sort of on a spiritual level, on a deeper level, that their life has become about methadone, and methadone is who they are, methadone is who they'll always be, and that methadone is at the core of who they are. But I think it all stems from the fact they truly believe that this chemical gets into their body, stays in their body, affects their body. And though they know that it's helping them get off of the street drugs, I do think there is some fear and anxiety around the chemical being in their body and how that affects just day-to-day processing. So yeah, a phrase I really do hear often is methadone is in my bones, or when people talk to me about wanting to get off of methadone, because that's what we're doing with the hyperbaric oxygen project, is helping people to lower their methadone dose. When we speak about that, a lot of the reasons why people say they want to reduce their methadone is because they fear it's getting in their bones. So a lot of different interpretations as to exactly what that means for people. People like to quote research to me also. They've read something, they've heard something, they saw an article somewhere about methadone and how dangerous it can be and how it physically gets into the bones. A lot of the time when I push and ask a few questions on that, they're not really sure where the science stands, but that is definitely something that comes up a lot, is it's in the bones. So something that's really important and something that I try to advocate for to the best of my abilities during my research is to actually ask the people who are involved in methadone and opioid use disorder to speak about it, to share their experiences, to be involved in their own care. That's really important across clinical care broadly. Any time you're talking to a patient, a service user, a client, you want them involved in their own care as much as possible. And we would all want that. No matter what anyone is going through, you don't want someone telling you what you need. You want to have a discussion about what you need. And the substance use, opioid use, methadone populations are no different to you and I. They want to be involved in discussions. They want to be a part of their care. They want to be involved as much as possible. There are obviously restrictions to that, and they cannot be in control of everything. You cannot ask someone, hey, what dose would you like today? It's not as simple as that. But where possible, it is really, really important that we involve patients, service users, clients in their care, in policy making, in law making, in the way it's spoken about in the media. It's just really important to rope these people in as much as possible, and I really want to advocate for that.